Now I request Dr. Riddhi, KHENI, please come to the dais.
Good afternoon, everyone. I am Dr. Riddhi, KHENI, presenting my study on clinical outcomes and management of acute pediatric ocular surface burns, a tertiary eye care study. As we all know, ocular surface burns in its acute form is an ophthalmic emergency, and its severity depends on type of agent, exposure duration, and time of presentation. Especially in pediatric age group, it often occurs due to household chemicals, firecrackers, and accidental exposures. Our aim is to study complete epithelialization time, extent of corneal vascularization, extent of symblepharon, and visual outcomes, and also to study various interventions, emphasize importance of early intervention and preventive measures. It is a retrospective observational hospital-based study of 22 eyes of 17 pediatric patients. We included patients of age less than 14 years and having injury within 1 month, and excluded the patient having a coexisting ocular infection and extensively bodily surface burns. We analyzed their demographic details and recorded the intervention done in its immediate phase as well as in the subsequent follow-up, medical as well as surgical. We evaluated patient on torchlight as well as or slit lamp and graded as per Dua's classification. Outcome measured were complete epithelialization time on scheduled intervals, corneal vascularization extent in clock hour positions, symblepharon as per grade, and visual acuity improvement of more than 2 lines on Snellen's grade compared to on presentation. All these parameters were measured for gender, type of agent, grade of injury, and time of presentation. Results seen were age range from 1 to 11 years, male is to female ratios 8 is to 9, 5 patients showed bilateral injury, and most common agents were firecracker and tuna. Approx 50% patient presented on the same day, whereas there were 2 patients who presented even after 15 days. Mean epithelialization time was seen highest with higher grade of injury, with alkali, with patient presented late, and in females. Corneal vascularization of more than 6 grade was also seen highest with higher grade of injury with alkali in patient presented late and in females. It is statistically also significant with grade of injury. Symblepharon formation of severe grade was also seen higher with higher grade of injury with alkali, with late presenters and in females, and it is also statistically significant with grade of injury. Most common interventions done were debridement and tarsography. One male patient having Lyme injury of Dua's grade 5 required tectonic lamellar patch grafting. Approx 60% patient showed visual acuity improvement, and none of the eye was lost to phthisis. We compared our study to Cat et al. And Vajpayee et al. Study. Both of these are Indian studies. We found female predominance in our study, whereas unilaterality and Lyme as an offending agent was the common finding. Firecracker was an additional offending agent in our study. Approx 54% eyes required surgical intervention in our study, where, compared to 47% in Cat et al. And 85% in Vajpayee et al. Study. Being a retrospective study, we had a very limited data. Psychological impact and economical burden was not studied here, but it can be the future provision. Severe pediatric ocular burns, especially with Lyme and firecracker, can lead to poorer outcomes, and as these injuries are more common in household settings, awareness and supervision can be the key to its prevention. Basic knowledge regarding primary management and timely referral to higher center, as well as multidisciplinary approach are essential for preserving the eye integrity, improving the cosmesis, and enhancing the overall quality of life of an affected individual. These are my references. Thank you.
For the grade 4 injury, how many patients you had?
Grade 4, ma'am, there were 4 patients.
So what did you do for those patients?
Those patients were for in immediate phase. When they came, we did the debridement or first ocular wash was given. For then if debridement was necessary, then debridement was done under local anesthesia or general anesthesia. Then we evaluated for the DUA's grading, further classification, and then the further management, surgical management if required was done.
So what was done? Grade 4. You said grade 4. That is
One
very bad.
one
Yeah.
patient required tenonplasty, ma'am.
Tenonplasty?
Yes, ma'am.
Yes. Okay. And other than tenonplasty, anything else? Was it very bad that it needed anything else? Only one. Another 3? Not sure. You are not the primary doctor. How many patients underwent amniotic membrane?
6 patients, ma'am.
Total how many were there? Total series?
Total 22 eyes of 17 patients.
Yes. In that 22, only 6 patients needed amniotic.
Yes, ma'am.
Others just
In
responded.
primary phase, 6 were done, and then after in secondary AMG was done in 4 patients.
All right.
Total 10 patients.
Thank you.